Welcome to Clinical Pharmacy and Pharmacotherapeutics 2. We are still in the discussion of gastrointestinal system therapeutics. So, for our disclosure and disclaimer, the content presented in this YouTube video contains pharmaceutical lectures that are solely for educational purposes and does not intend to provide medical advice. The information provided in this video is based on standard references, reputable sites, and updated guidelines. This lecture is not intended to replace professional medical advice or treatment. Viewers are advised to consult with their healthcare provider before making any medical decisions or changes to their treatment plan. The lecturer does not receive any compensation or financial benefit from the mention of any proprietary products or devices in this presentation. Any reference to such products or devices is purely for educational purposes and does not imply endorsement or promotion. By watching this video, viewers acknowledge that they are responsible for their own health decisions and that the content presented is not a substitute for professional medical advice or treatment. The lecturer and YouTube channel do not assume any liability for any damages or consequences arising from the use of the information provided in this video. So for the part 2 of our gastrointestinal therapeutics, we will be focusing on the discussion of nausea and vomiting, viral hepatitis, irritable bowel disease, and pancreatitis. For now, let's focus on nausea and vomiting. Nausea is defined as the inclination to vomit or as a feeling in the throat or epigastric region, alerting an individual that vomiting is imminent. In Filipino, we usually term this as pagduduwal or naduduwal. While vomiting is defined as the ejection or expulsion of gastric contents through the mouth, often requiring a forceful event. So ito yung sinasabi nating nagsusuka or nasusuka. Now, there are several etiologies concerning nausea and vomiting. First is gastrointestinal mechanism. Among the list, we have mechanical obstruction, meaning to say that there is a blockade or something is blocking the bowel. It can either be adhesions, hernias, bowel ischemia, necrosis, or perforation. When we see functional GI disorders or FGID, these are the disorders that are chronic in nature and has symptoms that includes abdominal pain, dysphagia, dyspepsia, diarrhea or constipation, and even bloating. Now, the third is organic GI disorders, meaning to say if it's organic GI disorder, there is structural abnormalities in the digestive system. Now, comparing the two, organic GI disorders and functional GI disorders, again, organic has structural abnormalities, while functional, the structure of the GI appears normal, but still there is a problem in the functioning. Now, going back to organic GI disorder, this is usually associated with frequent stooling, vomiting, and abdominal pain as signs and symptoms. Fourth one is acute gastroenteritis, or normally we term this as infectious diarrhea. So this is an inflammation of the gastrointestinal tract that includes stomach and the intestine and is exhibited by symptoms of diarrhea, vomiting, abdominal pain. And if it's infectious, in most cases, it has fever, dehydration, and lack of energy. So common causative agents to gastroenteritis, infectious in nature, would be viruses. You have also bacteria, fungi, and parasites. Now, specifically for gastroenteritis, if it's viral infection in nature, common viruses that we account for this one are rotaviruses. We also have the astroviruses and the noroviruses. And then we also have for bacterial infection, the most common is we have the staphylococcal food poisoning caused by Staphylococcus aureus. We also have shigellosis or bacillary dysentery. This is caused by several species of Shigella. We have Shigella dysentery, if you can remember, Flexneri, we have Boydii, and Sonei. But in humans, the most common species rather, that is transmitted through the fecal oral route is the Shigella dysentery. We also have, if you can remember, Salmonella which causes salmonellosis. So we have two species. You have the Salmonella enterica and the Salmonella bongori. But again, in humans, most common is the Salmonella enterica. Then under the Salmonella enterica, we have two serotypes, the enteriditis and typhi. So the typhi, this is the one that causes the typhoid fever. And also we have the E. coli, of course, no, which is a common normal microbiota of the colon. However, this causes pathogenic strains. Normally, if you can remember, we have the ETEC, the enterotoxigenic E. coli. We also have EIEC or the enteroinvasive E. coli. This is normally relative or parang comparable siya to shigellosis. However, they are different. We also have EHEC, if you can remember, the enterohemorrhagic E. coli. Uh, the strain normally, if you can remember the classification, the OI57H7. And then O is this refers to the O side of the side chain of the liposaccharide, and H for the flagella, for the characterization. And then we also have EPEC. So there are several, and EHEC as well. And then we also have cholera. Which is caused by Vibrio cholera. And of course, other microorganisms in the form of fungi and parasites. So next we have cardiovascular diseases in the form of acute myocardial infarction as causes. We have congestive heart failure and radiofrequency ablation. We also have for neurologic processes, those that increase intracranial pressure. Normally, the mechanism, specific mechanism would be unknown. No, however, this can be associated with triggers such as trauma, head trauma, and then we have migraine headache and vestibular disorders. We have several vestibular disorders. We can have vertigo or the benign paroxysmal positional vertigo or the BPPV or the positional vertigo that we usually know. This is the type of vertigo that there's a sudden feeling of vertigo in the form of swaying or spinning feeling. And then we can also have mice, rather acoustic neuroma or a tumor in the inner ear. We also have metabolic disorders that contribute to nausea and vomiting, such as diabetes mellitus, particularly diabetic ketoacidosis, Addison's disease, or the primary adrenal insufficiency. And then we have renal disease, particularly uremia. So when we say uremia, this is a clinical syndrome wherein there is an elevated concentration of urea in the blood. Psychiatric causes can also be attributed to nausea and vomiting. Particularly, we have psychogenic vomiting. So, psychogenic vomiting is a syndrome of recurrent vomiting without any organic pathology. And this normally occurs or results from emotional or psychic disturbances. We also have anxiety disorders. So in the form of generalized anxiety disorder, panic disorder. So we commonly see nausea and vomiting in panic disorder, and then phobia, and even separation anxiety. And then we also have anorexia nervosa and bulimia nervosa. These are eating disorders that have nausea and vomiting as manifestations. Then we have therapy-induced causes. Those are that are mediated by medications. That's why it's very important that pharmacists have to monitor and evaluate the nausea and vomiting capacity or potentials of medications because they can contribute to non-adherence and non-compliance. We also have drug withdrawal in the form of opiates and benzodiazepines. And then other miscellaneous causes in the form of pregnancy, noxious odors, and operative procedures. So we will have separate discussion for operative procedures, pregnancy, chemotherapy, and balance disorders. Now we move to the phases of emesis. So normally we have three phases. We have nausea, retching, and vomiting. Again, as we have mentioned, when we say nausea, that's the imminent need to vomit. And normally this is associated with gastric stasis. Gastric stasis or yung paggalaw ng gastrointestinal tract. Now, when we say retching, this is attributed to the labor movement of the abdominal and thoracic muscle before vomiting. So, if you can remember or kung may instance na kayo ay nagsuka na or 'di ba kapag, naduduwal ka na, merong part dun na parang naghe-heavily contract 'no, yung ating, abdominal cavity. So that's the retching. And then of course, the forceful, expulsion of the gastric content due to retroperistalsis, retro 'no, pabalik, na movement ng which is peristalsis, which is vomiting na po. Now, this is the complete pathogenesis of vomiting. So, based on the etiology, so for example, what we have mentioned kanina is the irritation of the GI mucosa. So, if there are inflammation, distensions, can be due to chemotherapy radiation. So, for example, in this pathway, this will lead to the activation of receptors in the gut mucosa, and that particular signal travels via the vagal and sympathetic afferent nerves. So once it happens, it will stimulate the solitary tract nucleus in the medulla, triggering the vomiting emetic center in the medulla. Then the vagus nerve and the enteric nervous system activation will lead to the following, no, the three most common: gastric relaxation, decreasing pylorus tone, retrograde duodenal peristalsis, no, yung pabalik, downward diaphragm rather contraction, abdominal chest wall muscle contraction or yung sa retching na nakikita natin, and then upper and lower esophageal sphincter relaxation and glottis closure, thus leading all to vomiting. So similar other triggers, like for example here, what I've mentioned a while ago for the intracranial. So if there's trauma, infection, tumor, or stroke in relation to different cerebrovascular condition, that will increase intracranial pressure. Although the exact mechanism is unknown, it will still trigger the vomiting emetic center. Now, there are some triggers that would have to activate different receptors, such as like for this one, for the disruption in inner ear balance or basically motion sickness, it will activate the histamine 1 and muscarinic 1 receptors in the vestibular center via the cerebellum. And eventually, it will also lead to the triggering of the vomiting emetic center in the medulla. So this gives us a logical approach on how vomiting would be addressed later and the different drugs and mechanisms that will be applied. So this is just a highlight of each of this step. Okay. So it would be more visual to you guys. So moving forward to the different types, let's start with CINV, or what we call the chemotherapy-induced nausea and vomiting. As it is, this is a nausea vomiting that occurs during chemotherapy. Now, if the occurrence is within 24 hours of chemotherapy administration, we normally term it as acute CINV. And now if the nausea and vomiting starts more than 24 hours after chemotherapy administration or the initial administration, no, we're pertaining here to the initial administration, it can be considered delay. Now, there are more specific classification to this one, and we have to be very particular on the characterization of each. So for CINV, So the more specific types would include, again, the acute CINV. So our description to this is that it's a nausea and vomiting that occurs within 24 hours or less than 24 hours after the initial administration. And this is triggered normally by the receptor 5-HT3 or 5-hydroxytryptamine 3. The second is the delayed. As we have mentioned a while ago, it is a type of CINV that the nausea and vomiting occurs more than 24 hours after the initial administration. It may also take at least 5 days. And this is triggered by the binding of substance P on the NKI receptor or the NK1 receptor. And then we have the third one, the anticipatory CINV. So when we say anticipatory, the nausea and vomiting occurs before chemotherapy. So normally it's by the term itself, anticipated. Okay. The effect of this one, this normally happens on the succeeding dosing or the succeeding cycles of the chemotherapy, since the person is had the idea of what or the extent of nausea and vomiting experience during the chemotherapy session. So in the succeeding cycles, the patient would be having or manifesting the anticipatory CINV. So that's why the common causes, or this is mediated by physiological and psychological factors. Then we also have the breakthrough CINV. This normally occurs within 5 days of initiating the chemotherapy despite the anti-emetic prophylaxis. So that's the idea of the breakthrough, meaning it was addressed, the patient was given an anti-emetic prophylaxis not to prevent the nausea and vomiting. However, still he or she manifested the nausea and vomiting. So breakthrough, that's the idea. And then of course we have the refractory CINV, which occurs after chemotherapy but on the subsequent therapies na po. So that would be one of the difference between the delayed. Say remember, if it's delayed, normally it's after chemotherapy, and even acute, it's after the initial administration of chemotherapy. For refractory, it's the after chemotherapy, but we are focusing on the subsequent treatment cycles. So, and of course, after, uh, it should also be noted that in refractory CINV, this occurs after chemotherapy on the subsequent cycles after failure on the anti-emetic agent or the chemotherapy agent. And then, of course, there are risk factors to CINV. So, factors that increase, okay, the occurrence of CINV would be, of course, if the patient had vomiting during a previous chemotherapy cycle, the type of chemotherapy drugs administered. So later on, you will evaluate the emetogenic potential of the different chemotherapy drugs. Um, Whatever female, it was noted in 3 studies that females have increased risk on nausea and vomiting, prior alcohol use. What else? Normally, first cycle of chemotherapy normally increases nausea and vomiting. History, if patient had history of nausea and vomiting. um, the number of hours of sleep the night before. So even us, we normally experience a possibility of nausea and vomiting if you have less sleep. And then uh, if there are also events of self-medication by the patient. Now, risks that would decrease the possibility of nausea and vomiting is on if it's on the second or third cycle of chemotherapy. That's why we have to also evaluate and assess the chances of occurrence of refractory nausea and vomiting, because normally on the second or third cycle or the succeeding cycles, the patient would have decreased risk due to adaptation of the body, but nonetheless, it can still change depending on the susceptibility of the patient. And then here are the list of the emetogenic potential of the different drugs using chemotherapy. So we have intravenous drugs and oral drugs. Like for example, HEC is meaning high emetogenic capacity. So meaning 90% of the time or 90% of the population given would have automatic emetogenic effect. So we have carmocysteine, anthracycline, doxorubicin, streptozotocin. We have cisplatin, cyclophosphamide. And then we also have for the medium or medial emetogenic capacity, doxorubicin, daunorubicin, arsenic trioxide, amifostine, carmostine, carboplatin. So the next column is attributed to the oral drugs. And then for low emetogenic, so this is just a continuation. We have melphalan, irinotecan, epirubicin, ifosfamide. And the low emetogenic capacity, we have on the list mitomycin, docetaxel, and then thalidomide is also here. Remember that in the previous use of thalidomide, now prior to its banning for pregnancy women, it was used for morning sickness because it really has the a very less capacity cause emetogenesis. However, the sad part is that it caused a very serious adverse event, which is pocomelia. And then this is just a continuation of the low emetogenic capacity, low emetogenic chemotherapy rather, sorry. And then, of course, the minimal. Okay, so we have rituximab, trastuzumab, vinblastine, the Vinca alkaloids are here. We have bleomycin, busulfan, and for the oral, we have chlorambucil, melphalan, methotrexate, and the others. So again, sorry for it's highly emetogenic chemotherapy. Okay. Now for the management, so based on our reference, 2021, this is a 2021 literature, wherein they have categorized the management according to the emetogenic capacity of the agent. So if it's an HEC agent, on day one, they suggested the use of aprepitan, which is a 5-HTT receptor antagonist, and a combination with dexamethasone. We can also have fosaprepitan. You have rolapitan and nitupitan. Another is we can have olanzapine, palonosetron, and dexamethasone combination, or aprepitan, dexamethasone, and olanzapine combination for the day one. And then on days 2, 3, and 4, aprepitan on day 2 and 3, and dexamethasones on day 2, 3, and 4. So if you can see, there's a tapering of dosing here, especially in the use of steroids. So in this combination, if we started on olanzapine, palonosetron, and dexamethasone, on days 2 and 3 and 4, we only gonna use olanzapine daily. Okay. Again, these are recommended management guideline, but individual differences or treatment therapies would be applied based on patient's response. And then for MEC, or moderately emetogenic chemotherapy, so we have a 5-HT3 receptor antagonist and dexamethasone combination still. But here you would see that on days 2 and 3, so it would be limited to days 2 and 3, we will be using either dexamethasone or the 5-HT3 receptor antagonist monotherapy. On the previews for the high emetogenic, we do have a combination, but this one it's on monotherapy. And then for the low emetogenic chemotherapy, So 1 dose of dexamethasone, metoclopramide, prochlorperazine, or 5-HT3 receptor antagonist can be used. And for minimally emetogenic therapy, no antiemetic was recommended. So next type of nausea and vomiting is we have the PONV, or the post-operative nausea and vomiting. So for this one, it's typically used to describe nausea and vomiting or retching in the post-anesthesia care unit, or PACU, or in the immediate 24 post-operative hours, meaning to say the nausea and vomiting is triggered after the surgery. So normally this is associated, of course, due to the exposure of the patient to the anesthesia and other agents during the procedure. So we also have the PDNV, or the post-discharge nausea and vomiting. So this refers to symptoms that occur after the discharge for outpatient procedures. That's why you would normally see, if you become a clinical pharmacist in the ORRR, you would also observe that some patients would be given antiemetics even after discharge. So more likely because they are considered PNDV. We also have the balance disorder. So basically, these are conditions that causes dizziness and unsteadiness in relation to different body positioning. So that's why we can attribute it to normally motion sickness and vestibular disturbances, as I have mentioned in the previous etiologies. So in this case, patients may experience dizziness and vertigo in addition to the nausea and vomiting. And normally, if a patient is susceptible to motion sickness, our general approach is to provide preventive medication so as to minimize the exposure to movement, restrict visual activity, which can trigger the balance disorder, and also to look at different causation on the balance disorder. So just like what I have mentioned a while ago in the previous slides, if there are different triggers to the imbalances or the vestibular disorders. So the keynote idea to balance disorder is that since these are vestibular system, and normally, the vestibular system is repleted with muscarinic type cholinergic and histaminic receptors. We normally address motion sickness with treatment with anticholinergic and antihistamines. Okay, so that's one thing that you have to remember in terms of treatment. And one of the common treatment for motion sickness, we have transdermal scopolamine. Okay, and this can also, but however, um, this can also be given in other routes, but the most common is transdermal. Then we have the NVP, which is nausea vomiting in pregnancy. And this is defined as a condition mostly occurring in early pregnancy or the first trimester of pregnancy. Although this may be highly variant to different women, but majority of women, pregnant women, are affected with this one. So what we have to be cautioned is that since the patient is pregnant, the choice of medication, we have to prioritize the evaluation on the teratogenic potential of the therapy. So we have to weigh the risks and benefits for this particular patient. Normally, the treatment for this one is would include the pyridoxine. Now for NVP, we have several etiologies. It can either be obstetric, particularly in nature, or non-obstetric. For obstetric, we have the morning sickness. So normally this happens in the first trimester. We also have hyperemesis gravidarum. So hyperemesis gravidarum is a severe nausea and vomiting during pregnancy, and it's an emergency condition in terms that it will possibly lead to dehydration, weight loss, and ketosis for the patient. So that's why it's very important to recognize this and to have it really addressed upon admission. And then hydatidiform mole. This is usually associated with gestational trophoblastic diseases. Next is non-obstetric, such as gastroenteritis, bowel obstruction, and UTI or pyelonephritis. Meaning to say that this one, the first one, that's related to the pregnancy. The second one, it's the patient still pregnant, but the causes of the nausea and vomiting can be outside pregnancy. Like, for example, gastroenteritis, as we have mentioned a while ago, there's an inflammation in the intestine. Uh, Especially if it's triggered with infection, any bowel obstructions, specifically, and UTI or pyelonephritis. Now, here is a recommended physical examination finding in pregnant patient with vomiting. So normally, there's lethargy and agitation. There would be dry mucosa and icteric sclera, especially if there is hyperemesis gravidarum, so leading to dehydration. There's a meningismus, which is stiffness to the passive flexion. For the gastrointestinal, so distension with tympani, peritoneal signs, girding, rigidity, rebound. For genitourinary, this is flank tenderness to percussion. Grape-like tissue from the cervix, and for neurologic, it can either lead to confusion, photophobia, focal weakness, and nystagmus. Again, this is mostly associated with hyperemesis gravidarum. So, and another literature, specifically for Medscape, they have provided the pregnancy unique quantification of emesis and nausea index. So the patient had to answer the three questions, and the total score is the sum of the replies of the patient. So the total score would be assessed in this legend. If it's the score is less than 6, it's mild and VP. For 7 to 12, it's moderate, and then severe if it's more than 13. Then the suggested for nausea and vomiting during early pregnancy, since again we have mentioned that in pregnancy our main focus would be the benefit and risk, since we need to address the nausea and vomiting, but we also have to consider the safety of the fetus or the baby. So the common medications, we have vitamin B6 or pyridoxine, with or without doxylamine, promethazine, metoclopramide, and ondansetron are also options. However, for the initial, the recommended would be vitamin B6 or pyridoxine with or without doxylamine. And then for the general treatments that we have in nausea and vomiting, again, it would be highly dependent on the etiology. So among the treatments available, we have antacids and histamine 2 receptor antagonists. So for antacids, it can either be single or in combination antacid products, like in the form of magnesium, aluminum hydroxide, calcium carbonate. And this usually provide sufficient relief for simple nausea and vomiting, especially if the condition is related to GERD or PUD. So we can also have HORA in the form of cimetidine, famotidine, nisatidine, and ranitidine. So again, this is if it's the nausea and vomiting is associated with heartburn or GERD or even PUD. We also have the antihistamine anticholinergic drug. So normally this is appropriate treatment for simple nausea and vomiting, and if the etiology is vestibular or related to motion sickness. However, again, we have to note that since this is antihistamine anticholinergic, common adverse reactions would be drowsiness or confusion, blurred vision, dry mouth, urinary retention, and possible tachycardia if given to elderly patients. We also have benzodiazepines. They are relatively weak antiemetics. And if you can remember, we also have mentioned that some benzodiazepines can also trigger the nausea and vomiting. But in most cases, the attribution of benzodiazepine is to prevent anxiety or anticipatory nausea and vomiting. So, common to this, we use alprazolam and lorazepam as adjunct to other antiemetics. And then we also have deuterophenones and then cannabinoids in the form of dronabinol. Although these are more on the CINV type, refractory CINV antiemetics. But these are not noted as first-line agents. We also have corticosteroids, and as we have mentioned, dexamethasone is commonly used, and this is mostly applicable to management of chemotherapy-induced nausea and vomiting. It can also be used with post-operative nausea and vomiting, no, PONV, either in single or in combination with the 5-hydroxytryptamine 3 receptor antagonist. And then, ayan, the 5-hydroxytryptamine 3 receptor antagonist in the form of dolasetron, granisetron, those that end with setron. Ondansetron, palonosetron. So those are the medication. So we use it in CINV, PONV, and even radiation-induced nausea and vomiting. So common side effects of this treatment, you have constipation, headache, and asthenia. We also have the NK1 receptor antagonist or the substance P neurokinin 1 receptor antagonist. So as we have mentioned, example to this one is aprepitan, fosaprepitan. So the fosaprepitan is the injectable form of aprepitan. Okay, so this is normally indicated for multiple drug regimen and prophylaxis of nausea and vomiting, especially in high dose or highly emetogenic chemotherapy drugs. And then we have pinotiazines. So this is most useful in patients with simple nausea and vomiting, and it do have a rectal administration of the drug, especially if oral or parenteral administration is not feasible. So that's the advantage of this drug. And then we also have other miscellaneous agents in the form of metoclopramide. So as we have all know that this is a very common antiemetic, especially those in patients with gastroparesis, no, diabetic gastroparesis, and in most common nausea and vomiting, and of course olanzapine. So that's all for this discussion. So kindly wait for the posting of the sample case study for nausea and vomiting. Again, thank you.